Well, it is 5:34. I think we should proceed and start. Hello and welcome. My name is Jorge Delva. I'm the Dean of the Boston University School of Social Work and Director and Paul Farmer Professor of the Center for Innovation in Social Work and Health. Thank you everyone for joining us for the 2020 Hubie Jones Lecture in Urban Health, as we move our events to Zoom during these unprecedented times. And this is such a critical time in which we're in. For those of us working in social work, public health, healthcare, and other helping professions, advancing health equity and dismantling racist structures, which are part of our central work. I'm grateful to see all of you joining us tonight. I want to give a special thanks and welcome to Hubie and Kathy Jones. Thank you both for your leadership and partnership. Tonight, or this afternoon for some of you, we honor Hubie's enduring legacy. Hubie Jones, Dean Emeritus at the BU School of Social Work and lifelong change maker, has been involved in the creation and leadership of over 40 organizations in Boston. Hubie has dedicated his life to social justice and equity in every sphere. The Hubie Jones Lecture in Urban Health is an annual symposium that addresses critical issues at the intersection of health and social justice. This series was established by an anonymous donor to honor Hubie Jones' vision and accomplishments. Over the last 6 years, we've had featured leaders such as Paul Farmer, Adewale Troutman, and Don Berwick, among others, whose work to improve health and promote health equity have transformed local, national, and international systems. The lecture is hosted by the Center for Innovation in Social Work and Health here at the BU School of Social Work. Our goal is to provoke, thought, and stimulate action consistent with the center's mission to expand the impact of social work in healthcare and population health. We define health in broad terms, consistent with the World Health Organization, to include physical, mental, and social well-being, and to involve work at the individual, family, community, institutional, and societal levels. Tonight's lecture is particularly timely in light of everything we're experiencing in the world, from the COVID pandemic to racial violence, and so much more. We're thrilled to have Dr. David Williams as our Hubie Jones Lecture speaker this year. Dr. Williams' career has exemplified Hubie Jones' commitment to social and racial justice. Dr. Williams is the Florence Sprague, Norman, and Laura Smart Norman Professor of Public Health, Chair of the Department of Social and Behavioral Sciences at the Harvard T.H. School of Public Health, and Professor of African and African American Studies and Sociology at Harvard University. He is an internationally recognized social scientist focused on social influences on health. His research has enhanced our understanding of the complex ways in which socioeconomic status, race, stress, racism, health behavior, and religious involvement can affect health. Dr. Williams, we're so grateful you have joined us, and we look forward to learning from you. After Dr. Williams' lecture, we will have some time for audience questions. Please type your questions into the chat window in Zoom, and we will take as many as time allows. A few final housekeeping items. If you're a social worker needing continuing education credits for this event, you will have received a link in your email confirmation to a quiz that you must complete to receive continuing education credits. By the way, this event is also being recorded, and it will be available on our website, ciswh.org. ciswh.org. Thank you again for joining us, and I hereby present to you Dr. David Williams.
Good evening. It is truly an honor to be here as part of the speaker for this Hubie Jones lecture. And it's a signal honor to be introduced by Dr. Jorge Delva, the Dean of the School of Social Work. Dr. Jorge Delva and I go back. We were both faculty many years ago at the University of Michigan and worked together. and it's just an honor to reconnect with a wonderful colleague and friend, and so really a pleasure to be here. I'm going to share my screen so that you can see my PowerPoint slides that I have for tonight. And I have a lot of territory to cover. I'm going to focus on societal inequities in health and what we can do to effectively reduce them. I'm going to jump right into my presentation. I want to begin by looking at deaths from COVID-19. That is the current pandemic that has gripped our attention. And this is the latest data we have of the mortality rate, deaths per 100,000. And you can see the elevated levels for Blacks and Hispanics in the United States. One way to make those numbers real is to say that if all racial ethnic groups had died at the same rate as white Americans, 20,800 Black Americans who have died from COVID would not have died. 10,900 Latino Americans who have died from COVID would not have died. And 700 Native Americans who have died from COVID would still be alive today. What we see with COVID-19, COVID-19 has not created racial inequities in health. It has just shown a magnifying glass on a pattern that is found around the world. So here is one example, data for the United Kingdom. And you can see these are odds ratios. Blacks in England and Wales have a death rate from COVID-19 that is 4.2 times higher than that of whites. Bangladeshi and Pakistani males have a death rate 3.6 times higher than that of whites and in England and Wales. And Indian males have a death rate that is 2.4 times higher than that of whites. And if we look at the data for females, you see a very similar pattern of markedly elevated death rates from COVID-19 for stigmatized racial populations in the United Kingdom. What's true for COVID-19 is true for health outcomes in general. So infant mortality, a widely used indicator of health in international comparisons. Infant mortality captures the rate at which a baby dies before its first birthday. And you could see in 2015 in the United States that Black babies were more than twice as likely to die before their first birthday than white infants, and also elevated risk for Native American infants in the United States. I just want to show you, it's a global pattern. Here is infant mortality rates by ethnicity for England in 2014, and you could see the elevated rates for Blacks from Africa, Blacks from the Caribbean, Pakistanis, compared to the white British. And if we look at South Africa, you see exactly the same pattern, mirroring the racial categorization of the apartheid era. Blacks have the highest rates, then come coloreds, then come Indians, then come whites. And if we look around the world, in Latin America, the Afro-descended population have higher infant death rates in Costa Rica, in Panama, in Uruguay, in Venezuela, in Brazil, in Ecuador, in Colombia, not in Argentina. But you see a pronounced pattern across outcomes. And the indigenous population, the same story. Here in Latin America, in Costa Rica, in Uruguay, in Mexico, in Colombia, Brazil, Venezuela, Peru, Ecuador, Panama, Guatemala, Bolivia, you can see the indigenous population has higher death rates. So we are seeing a global phenomenon where disadvantaged populations are doing much worse in terms of health. What we also see is what I call some ominous storm clouds. There's some trends that are emerging that are quite disconcerting about what we can expect in the future. Here is work from one of my colleagues at Harvard, Steve Gortmaker. He has shown that at age 2, Black and Latino children are more likely to be obese than white ones. And when he looks at all Americans, teenagers, young people, age 2 to 19, 57% of all American children and youth aged 2 to 19 today will be obese by age 35. For African Americans and Latinos, it's almost 70% will be obese by age 35. That portends really serious chronic illnesses that will accompany these high rates of obesity. And then there is some disturbing data about the high and increasing level of mental health problems in these United States. This is a study that looked between 1993 and 2012, used national data, suicide rates among elementary school children in the United States. And between 1993 and 2012, the suicide death rates declined markedly for white children in elementary school. They were stable for Latino and Asian children, but they doubled for Black children. So this is one of the few examples where we see African Americans having higher rates of suicide, and we see a doubling of the rate, as this slide showed, for Black boys between 1993 and 2012. Why do these inequities in health exist? Well, around the world, in virtually every society where we have data, there are large inequities in health by socioeconomic status, income, education, occupational status, and wealth. Here is one example with US data from the panel study of income dynamics. Overall death rates by income level in the United States. And what this chart shows is that low-income Americans, income less than 25,000, have a death rate that is 3 times higher than that of high-income Americans. But it's not just that those of low income are doing poorly. Every higher level of income is associated with a lower risk of death. It mirrors what we call a gradient effect of socioeconomic status. And those data then would suggest one reason why there'd be racial inequities in health, because there are large racial inequities in socioeconomic status in the United States. Here is national data for the United States from a 2019 report from the US Census Bureau, showing us median household income levels by race and ethnicity. And this chart, I'm just translating that data in a way that you can't miss the point. I'm standardizing on the household income of whites as $1. And for every $1 of household income white households receive, Asian households receive $1.23. Asian households are heavily made up of immigrants, and they come to the United States with relatively high levels of education, markedly higher than that of whites. And Asian households have more persons contributing to household income. But if we look at the historically disadvantaged groups, for every $1 of household income white households receive, Latino households receive 73 cents, and Native American and African American households receive 59 cents. What is stunning about this 59 cents figure for African Americans is that it's identical to the Black-white gap in income in 1978. You heard me correct, I did not misspeak. 1978, the peak year of the narrowing of the Black-white gap in income as a result of the anti-poverty policies of the 60s and 70s and the civil rights policies, we had narrowed the gap to 59 cents. And in 2018, the gap is still 59 cents. Has it been stable at 59 cents over time? No, it hasn't. It got much worse than 59 cents during the decade of the 1980s. Reaganomics was not good to Black America. And it wasn't until 1994 that it got back up to where it had been in 1978. And it's a penny up and down from that since then. Most of my students think we have made more progress in the United States than that. And as bad as these income data show, they understate the racial differences in economic circumstances when we look at data on wealth. But before I look on data on wealth for the US, let me look on data on race and income in the United Kingdom. Since I showed you data from the United Kingdom, for every pound of weekly income the white majority earns, Chinese earn 76p, Black from the Caribbeans earn 77p, and Blacks from Africa earn 60p. So what we are seeing is a similar racial gap in income in the United Kingdom. And I was saying these, just looking at income understates the racial gap in economic status, because income captures the flow of resources into the household. It doesn't tell us anything about the economic reserves that cushion shortfalls of income. We get that from data on wealth, home equity, and checking and savings accounts, and money market accounts, and CDs, and mutual funds, the assets, financial assets that households have. The latest Federal Reserve Board data shows for every dollar of wealth that white households have, Black households have 10 pennies and Latino households have 12 pennies. And if we look at data for the UK, we see a similar pattern. For every pound of wealth that the white British have, Pakistanis have 50 pence, Blacks from the Caribbean 20 pence, Blacks from Africa 10 pence, Bangladeshis 10 pence. So I'm showing you across societies, you are seeing very similar patterns of inequality in terms of economic status. When my career started, most researchers thought that the racial differences in health was simply a function of racial differences in socioeconomic status. And if you looked at Blacks and whites, for example, at the same levels of income and education, race would not matter. We now know that life is more complicated than that. And I want to illustrate that with national data for the United States. Life expectancy at age 25. At age 25, the average white person will live 5 years longer than the average African American. However, if we look within the white population by education, whites with a college degree or more education live 6.4 years longer than whites who have not finished high school. Importantly, the education gap and also the income gap is larger within race, is larger than the racial gap. And the same is true for African Americans. Those with a college degree live 5.3 years longer than those who have not finished high school, again, bigger than the 5-year gap. So what does this tell us? There's something about your income or education that matters for your health regardless of your race. But the data also tell us there's something else about race that matters even after we've taken income and education into account. You see, white high school dropouts live 3.1 years longer than Black high school dropouts, and that gap widens as education increases, with whites with a college degree living 4.2 years longer than African Americans with a college degree or more education. And this stunning statistic, and remember this is national data for the US, the best off African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who have finished high school. National data for the US. So what does this tell us? There's something about race that matters for your health, even after you've taken income and education into account. And this is not only true in the US. I'm going to show you data from COVID-19 mortality from the UK. Here is the data I've shown you before for men. The large differences, 4.2 times higher for Blacks compared to whites. And even after you've statistically adjusted for age and urbanicity and income and education and housing tenure and health, Blacks in the UK still have a 90% higher death rate than that of whites. And if we look among males and we look among females, you see here is the gap. And even after you've statistically adjusted for all these explanatory socioeconomic and demographic characteristics, there still is an elevated rate of death for Blacks in the UK and Bangladeshis and Pakistanis. So researchers have been asking the question, could racism be a critical missing piece of the puzzle to understand the patterning of racial inequities in health? What do I mean by racism? I see racism not primarily as the beliefs and behavior of individuals. I see racism as an organized societal system, a system that categorizes and ranks, devalues and disempowers some groups, differentially allocates opportunities and resources to some groups. It's premised on an ideology of inferiority, and it can lead to the development of negative attitudes and beliefs, prejudice and stereotypes, and differential treatment, discrimination, by individuals and societal institutions. I believe it's important to distinguish individual discrimination from institutional, structural, systemic discrimination. Here is an example of institutional discrimination. We are coming up on a presidential election. In the 2012 presidential election, this is national data on how long Americans stood in line at a precinct waiting to vote in 2012. And what you can see, on average, African Americans waited 23 minutes in line, whites waited 12 minutes. That's a big difference, almost twice as long. Importantly, none of that reflected the behavior of local precinct workers. They were not telling blacks to stand aside and let whites go ahead of them. They were not delaying them in any way or treating them badly in any way. Instead, what it reflected was where you voted and what was the budget allocation, what was the space constraints, what was the staffing level of the precinct. It was all administrative and bureaucratic policies and procedures. And although all of the precinct workers treated everyone the same, but nonetheless, there were striking differences in outcome. And folks, some of the most powerful ways in which racism operates are ways that are institutional, structural, systemic. They are beneath the radar screen and we don't even see them. For example, residential segregation is an example of structural institutional racism that has pervasive adverse effects on health. What are the effects on health? John Sell wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa in the early 20th century looked across the Atlantic and saw segregation in the United States, and they said, brilliant, we can implement that in our country. Importantly, he argues that residential segregation by race, that your race determines where you could live, was one of the single most successful domestic policies of the 20th century in the United States. Well, and you're saying, what does place have to do with anything? How does segregation matter? I would like you to think with me for a minute about segregation as a toxic emission produced by an industrial plant. It's imperceptible, but valuable resources disappear when it shows up in a community. Valuable resources like quality schools and safe playgrounds and good jobs and healthy air and water and safe housing and transportation and healthcare. How powerful is segregation? Let's consider some empirical evidence. Two of my colleagues at Harvard, William Julius Wilson and Robert Sampson, studied 171 largest cities in the United States. And they said because of segregation, there isn't even one city where whites live under equal conditions to those of blacks. And that the worst urban context in which whites reside is considerably better than the average context of black communities. Well, that was a 1995 paper. So have things gotten better? I want to draw here on the research of my former colleague, Dolores Acevedo Garcia. She has created a 24-item neighborhood opportunity index and ranks every county in the United States by that index. It includes the quality of schools and the quality of early childhood centers, the graduation rate, the percentage of adults with high-skilled jobs, the level of income and home ownership, unemployment rate, the quality of air and water and hazardous waste sites, exposure to them, and green space and healthy food outlets and walkability. 24 items that capture opportunity at a level of place. And this is what she found, and this is a 2020 publication. She finds that if you look in the 100 largest metropolitan areas in the United States, 2 out of every 3 black children, 2 out of 3, 67% of black children in America are growing up in a very low or low opportunity neighborhood. That is similarly true for 58% of Latino kids and 53% of Native American kids, compared to about 1 in 5 white and Asian kids. On the other hand, if you look at who is living in high and very high opportunity neighborhoods, almost 2/3 of white and Asian kids in high opportunity neighborhoods compared to 1 in 5 Black or Latino kids. So the inequality that we see in our society is heavily driven by place. In fact, we have strong empirical evidence that it is residential segregation that creates these large racial ethnic differences that we see in income and education and wealth. David Cutler, an economist at Harvard University, studied a national sample of Blacks and whites and showed statistically, if you could eliminate residential segregation, you would completely erase Black-white differences in income, in education, and in unemployment, and Black-white differences in single motherhood by 2/3. All of these differences are linked to opportunity, linked to place. Another Harvard economist, Raj Chetty, has done an intergenerational analysis. He's looked at Black boys and white boys who are growing up in households with similar levels of income. And he looks at how does the next generation do. And he finds in 99% of census tracts, Black boys who start out life at the same level of income of white boys are earning less income in their own lives. Why? Because they live in neighborhoods that differ in access to opportunity. Black boys do as well as white boys if they're in neighborhoods with good resources, but that's not true in 99% of census tracts in the United States. So what am I talking about, the inequities we see? We sometimes think of them, these racial inequities, as reflecting a broken system. I would argue they are not reflecting a broken system. Instead, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. These inequities we see are not accidents, are not acts of God. They illustrate how institutional, systemic, structural racism has produced a truly rigged system in these United States. And what does low economic status mean? It means that even though we're all in the same storm, when you are low in income and low in wealth, we're in the same pandemic, but we are in different boats. And some boats are better able to weather the storm than others. And we see this so dramatically with COVID. Not everyone can work from home. Essential workers don't have a choice when they work at low-wage, non-salaried workers with unpredictable hours, and they live in overcrowded housing. Social distancing is not a viable option. And then what the research has shown, the research that I have done and others have done, is that persons, populations of color, of low economic status, living in disadvantaged, segregated neighborhoods, they have higher levels of stress, economic stress and psychosocial stress, higher levels of unemployment, greater difficulties in making ends meet at the end of the month. Also high exposure to physical and chemical stresses and high exposure to discrimination. And all of this stress takes a toll on their lives. In fact, Martin Luther King said that discrimination was a hellhound that gnawed at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them. Well, what is the evidence of discrimination? Here is a scale I developed, the everyday discrimination scale. 9 items that capture little indignities, being treated with less courtesy and respect than others, receiving poorer service than others than restaurants or stores, people acting as if they think you are not smart or they're afraid of you or they think you are dishonest or they're better than you are. A lot of little indignities. And what the research shows is that these indignities chip away at the well-being and health of individuals on a daily basis. There are more than 200 published scientific studies from around the world that have used the everyday discrimination scale. And what have they found? They have found that people who score high on everyday discrimination are more likely to get breast cancer, more likely to have type 2 diabetes, more likely to score high on metabolic syndrome, more likely to engage in high risk health behaviors, more likely to have risk factors for subclinical heart disease, more likely to have high blood pressure, more likely to have poor sleep quality and quantity, more likely to have biological dysregulation, higher levels of inflammation, higher level of cortisol, shorter telomere length, more likely to be obese, less likely to follow their doctor's recommendations for screenings, and more likely to have mental health problems. So this is a broad range of disease conditions that have all been linked to exposure to discrimination as one additional stress on top of all the other stresses that people are dealing with. And what has research showed? These are some of my colleagues at Harvard that have shown that the chemical, physical stressors like air pollution, persons who live in areas of high air pollution are more likely to have severe cases of COVID-19 and more likely to die from COVID-19. And who is living in those places? The poor of all races and then populations of color. What's the consequence of all of this exposure to stress? Researchers are using the terms accelerated aging or premature aging or biological weathering to capture the earlier onset of chronic disease. Let's take the term weathering. What do we mean by weathering? Imagine a drop of water falling from the rooftop of the building you're sitting in to the concrete sidewalk below. And imagine water dripped today. It's no big deal. But if water dripped, drip, drip, a steady drip of water, day in, day out, week in, week out, month in, month out, the concrete sidewalk would become weathered. It would become eroded by the constant exposure to adversity. And what research is teaching us is that in these United States, your age doesn't only capture how long you have lived, but if you have lived in a bad environment with high levels of physical, chemical, psychosocial stresses and discrimination, your age is also capturing how long you have been exposed to bad environmental conditions and how physiologically compromised you have become as a result of those exposures. Here is national data from CDC. And you can see at the same chronological age, African Americans are much more likely than whites to have high blood pressure, much more likely than whites to have diabetes. And so these chronic diseases that they suffer from are linked, are consequences of the living and working conditions and high levels of stress that they're exposed to. And that helps us to understand what happens with COVID-19. Here is a study from New York City, 12 hospitals, nearly 6,000 patients. People who were hospitalized in New York for COVID-19, 57% of them had high blood pressure, 42% were obese, 34% had diabetes, 18% had heart disease. And in fact, if you look at all the people hospitalized, only 6% of people hospitalized did not have at least one of those conditions, and only 6% had only one. So 88% of the people hospitalized had more than one of these chronic conditions driven by the living and working conditions that puts them at higher risk of a severe case and death from COVID-19. So I've talked about the problem. I've described it in excruciating detail. What can we do about it? Strategy number one, we need to create what I call communities of opportunity to minimize, neutralize, and dismantle the systems of racism that have created inequities in health. What would communities of opportunity look like? Well, they would invest in early childhood. One example of the power of doing that, the Abecedarian Project in Chapel Hill, North Carolina, took children at birth, randomized them, poor children, 80% of them African American, randomized them to an early childhood program, a nurturing environment, good nutrition, good pediatric care, good intellectual stimulation, and the kids are there from birth to age 5. By age 21, their health is better, their educational performance is better, vocational assets are better. By their mid-30s, those kids who got this good program, birth through 5, they are doing better, markedly lower level risk for cardiovascular disease and metabolic disease. For example, here you can see the kids who got the program, their systolic blood pressure in their mid-30s is 126. Other kids in that community who didn't get the program, it's 143. Large difference in systolic blood pressure linked to an intervention birth through age 5. What we do for our kids early matters profoundly. What else would communities of opportunity do? They would reduce childhood poverty. We have markedly elevated rates of childhood poverty in the United States. This is from the UNICEF report. US ranked 34th in the world on childhood poverty. And there are dramatic variations by race. 1/3 of Native American and Black kids almost are growing up in childhood poverty. More than 1/4 of Latino kids and 11% of Asian and white kids. High rates of childhood poverty. Here is a table from the UNICEF report. What it shows, and this is really important, it shows, let's look at Ireland. The economy in Ireland produces a childhood poverty rate of 42%. That's what the economic system produces. That's the rate before taxes and transfers. But taxes and transfers reflects a society's preferences, its policy preferences, reflects its values of what is important to the people. And after taxes and transfers, the child poverty rate in Ireland is reduced from 42% to 8%. And you could see what other countries are doing. In the US, our economy produces a childhood poverty rate of 24%, and after taxes and transfers, it's reduced 1 percentage point. And it's not that we don't know what to do. There's a recent report from the National Academy of Sciences of the ways in which we can cut the childhood poverty rate by 50% in the next 10 years. There are a broad range of solutions for the political left or the political right that could be implemented. There's a lot that we can do. Nelson Mandela reminds us, there can be no keener revelation of a society's soul than the way in which it treats its children. We have to do better in this country in treating our children. What else would communities of opportunity do? They would enhance income and employment opportunities for youth and adults. One of the important things as we even think of children and what we do for children, one of the ways to make things better for children is to improve the quality of lives of their parents. And we have a lot of high quality scientific studies that show additional income from civil rights policies, that the earned income tax credits, that the implementation of Social Security and even Social Security cost of living adjustments, conditional cash transfer programs, additional income to Native American communities. All of these strategies have been studied that provide additional income in the pockets of individuals, leads to improved health with no health interventions. Here's an example. States that raise the state level minimum wage above the federal minimum, there are reductions in post-neonatal mortality and in low birth weight births in those states. And this study concluded if all states in 2014 had increased their minimum wage by $1, 2,790 fewer low birth weight babies would have been born in the US, and there would have been 518 fewer post-neonatal deaths for the year in the US. We know what to do. What else would communities of opportunity do? Well, they would improve neighborhood and housing conditions in the United States. Again, we have high quality scientific evidence that indicates just improving neighborhood conditions, no health intervention, 10 to 15 years later, people who will move to a better neighborhood, lower levels of obesity, lower levels of severe obesity, lower levels of diabetes risk. And here is a dramatic example, purpose-built communities. This is a program in the United States, started in Eastlake, Atlanta, that has shown it is possible to address all of the challenges faced by disadvantaged communities simultaneously. Come with me to Eastlake Meadows, African-American public housing project in 1995. 90% of the families who lived there were victims of a felony every year. Public housing, many units dilapidated. Only 13% of adults gainfully employed. The elementary school, one of the worst performing in the state of Georgia. Come with me today to the villages of Eastlake. There's been a 90% reduction in violent crime. There is mixed income housing. 50% of the residents qualify for public housing, 50% are at market rate. All able-bodied persons are employed, and the school, although over 60% of the kids qualify for reduced price lunch, so they are of low income, the school is one of the best performing elementary school in the state of Georgia. Purpose-built community shows it can be done. A coalition, a collaboration of residents of the housing project with a wealthy philanthropist and the Atlanta Public Housing Department has completely transformed that community. And purpose-built communities is offering free technical assistance to any community in the United States that wants to replicate their model. And there are many communities lining up to do exactly that. So we need to build communities of opportunity. What else do we need to do? We need to build more health into the delivery of healthcare. What do I mean by that? Well, first of all, we need to ensure that everyone has access to medical care. Here is an example we can learn from the state of Delaware. The state of Delaware was concerned about colorectal cancer, and they implemented a colorectal cancer screening program that was available to all residents of the state of Delaware within a certain range of the federal poverty level. And then they added to that colorectal cancer treatment to all residents up to 6.5 times the federal poverty level. And they built into that special outreach to African Americans and disadvantaged communities. What was the result of this program on colorectal cancer intervention? Well, this was the colorectal cancer, black-white differences, colorectal cancer screening when the program began. And 8 years later, they have eliminated the racial disparities in colorectal cancer screening. They eliminated the racial disparities in the incidence, that's the number of new cases of colorectal cancer, and they almost eliminated over 90% of the racial differences in colorectal cancer mortality. And the program saved the state money. It shows that it can be done. What else do we need to do if we build more health into the delivery of healthcare? We need to ensure that everyone receives high quality care. Back in 2002, 2003, the National Academy of Medicine, called the Institute of Medicine back in those days, issued the Unequal Treatment Report documenting racial bias in medical care, that Blacks and other minorities receive poorer quality care and less intensive care than whites. Studies indicate that that pattern still exists today, and there's work for all of us to do. I served on the Unequal Treatment Report Committee back then. There is still a lot of work for us to do in reducing implicit bias in healthcare encounters so that we can improve outcomes for individuals. What else do we need to do? We need to build more health into the delivery of medical care by providing care that addresses the social context. The World Health Organization asked the question, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? So it means we need to be asking a whole new set of questions. How can we, in the healthcare context, identify the non-medical health needs that patients have? How can we connect patients to local resources? How can we connect community residents to jobs when in many communities, the healthcare sector is the largest employer? How can we bring community health workers to link to services that patients have? Or we can do what the Boston Medical Center did, Dr. Zuckerman and his colleagues back in 2004, where they implemented the medical legal partnership so that the primary care provider in the pediatrics unit of the Boston Medical Center can refer a patient to a number of specialists, and one of those specialists is a lawyer. Yes, the Boston Medical Center has on-site attorneys to solve problems in the lives of their patients. You see, a mother brings a child with asthma. All the asthma medication is in the world will not help that child breathe symptom-free if that child goes back to live in the same moldy housing conditions that made the child sick in the first place. And the mother has tried and made no progress. It does make a difference when a lawyer calls and says you are in violation of the housing code of the state of Massachusetts and we will sue you if you don't fix the problem. What else do we need to do in health delivery of medical care? We need to diversify the workforce to meet the needs of all patients. Here is a study that highlights the importance of this. Just came out a few weeks ago. It's a study of 1.8 million hospital births in the state of Florida between 1992 to 2015. And what the study found, 1.8 million births, okay? When cared for by white doctors, Black babies are 3 times more likely than white newborns to die in the hospital. This disparity was cut in half when Black babies are cared for by a Black doctor. The biggest drop in deaths were in complex births and in hospitals that deliver more Black babies. There's much we need to do. What is the challenge we face today? In 2014, according to the Association of American Medical Colleges, there were 27 fewer African-American males in the first year of medical school than there had been in 1978. In the mid-1960s, 2.9% of all practicing physicians were Black. In 2012, 3.8% of all practicing physicians were Black. We need to really redouble efforts to open the gates of opportunity so that everyone gets the preparation and training that they can walk through the gates. Affirmative action in medicine has worked well for women, increasing the number of females in medicine graduating from medical school, has not worked as well for African Americans and Latinos and Native Americans, the historically disadvantaged groups. And we need to think of what we do to ensure that they are prepared to take advantage of the opportunity. As Plato has warned us, there is nothing so unfair as the equal treatment of unequal people. What else do we need to do? Strategy number 3, we need to raise awareness levels of racial inequities in health and build political will to address them. What's holding us back? What's the barriers we have to address? What's the elephant in the room why we haven't made more progress on this? Well, national data tells us that many Americans are unaware that racial disparities in health even exist. Many are indifferent, some are delusional. We have 3 communication challenges. We need to raise awareness levels of the problem of inequities, but much more importantly, we need to build the science base so that will guide us in developing the political will that we will address them. And importantly, to get political will, we first need to build empathy so that we care about the problem in the first place. Public opinion research indicates that Americans do not support interventions that help Blacks. Here is a study done. Here is a question asked in a national sample. Given business and industry special tax breaks for locating in poor and high unemployment areas, would you support the government doing that? And if people are asked of the government doing that for people in poor and high unemployment areas, 70% of whites said yes, they would support such programs. But if they're asked if they would do it for people living, for poor Blacks, only 43% support that. Among Blacks, we don't get much difference whether it's based on economic status or it's based on race. What is driving that? It's what researchers are calling an empathy gap. It was identified back in 1899 by W.E.B. Du Bois, an influential African-American social scientist of the late 19th and 20th century. In 1899, he published a book entitled The Philadelphia Negro. It talked about inequalities in health and other domains of life in Philadelphia in the late 19th century. But Du Bois, as he came to a chapter, the end of the chapter on Negro health, where he showed you statistics like I showed you tonight, he penned these words: the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And Du Bois continued, there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. In other words, Du Bois said that the fundamental problem with racial disparities in health is that for many Americans, we just don't care. He called it the peculiar attitude of the nation, the peculiar indifference. Today, researchers call it the empathy gap. And the empathy gap has been documented on every continent. We humans consistently have stronger empathic neural responses to the pain of someone of our own race than someone of a different race. That has been replicated everywhere. And what is very disturbing here is a study from the United States that shows at age 5, white children in America do not show any racial bias in terms of lack of empathy. By age 7, there is a tendency to show the lack of empathy for the suffering of Blacks. By age 10, it is pronounced. By age 10, it is pronounced. What reduces the gap in empathic brain activity? Individuation. That means focusing on the individual needs and not the social group to which the person belongs. Being on the same team, seeing yourself as on the same team with members of a racial outgroup, and greater interracial interaction in one's socialization is another strategy that works. We need to invest in research that will help us best identify how we can close the empathy gap in real world contexts so that we can develop the political will that every American will say, that's unacceptable in my country, that's unacceptable in my society. We will not tolerate such large inequities in health. Martin Luther King has told us that true compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. This evening, I have been talking about edifices that are producing beggars. And I want to leave you with the words of another son of Massachusetts, Robert F. Kennedy. Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. It is my hope that tonight, everyone in the sound of my voice would make a new commitment and determination that from this day forward, you will be a ripple of hope. And together, we can sweep down the mighty walls of injustice, oppression, and resistance that exist in our society. Thank you so much for your time and attention this evening.
Thank you, Dr. Williams, for your passionate presentation. I'm actually left a bit speechless. Thank you for deepening our understanding about the subject matter you covered tonight. I'm left sad, feeling sad, upset, but also invigorated to continue the work we're doing to fight against social and racial injustices and strengthen our pursuit of social, economic, and health equity. What a presentation. What an amazing presentation. Thank you. Thank you.
You're welcome.
We would now like to entertain questions from the audience. Please type your questions into the Zoom chat and we will take as many as time allows. Nelaja McCoy, the Center's Communication Manager and organizer of this event, will now take questions from the audience. Thank you, Nelaja.
Thank you, Dr. Williams, and thank you, Jorge. Actually, while we're waiting for people to type questions, so I'm just waiting for some to come in. Jorge, do you have any pressing questions that you might like to ask?
I was thinking about the concept of communities of opportunity there, as well as the empathy gap. I have this, and reading, I was connecting with also people's comments in the chat and the data that you show, how, not just how little progress there's been made, but we've gone backwards in so many ways. And the solutions are present. You describe many. How do we take these solutions and implement them nationally, not just a little experiment, and by little I don't mean to diminish their importance, right? How do we go to the next stage when it seems that we go one step forward, two steps backwards?
I think you've asked $1 million question. It is absolutely important. The paper I put at the end is a paper that I wrote with Dr. Lisa Cooper from Johns Hopkins that summarizes all of the scientific evidence that shows the interventions that would work. And one of the challenges is we have examples of interventions that have worked remarkably well. In fact, one of the things that I didn't emphasize is that many of these interventions that work, it not only worked, it saved society money. So it makes sense. They are investments, not expenses. They're investments for us. One of the challenges is we haven't really identified, or we haven't had the political will to scale up some of these programs. So they have been tested and shown to work, and there's a report and an academic paper that this is done, but we haven't taken the next step of really making the investments to scale up the kind of support. There are times I talk about one of the things we need is for a Marshall Plan for disadvantaged communities in the United States. The way in the post-World War II era, we helped to develop a Marshall Plan to rebuild Europe after the World War. We need to think of all communities, whether it's poor white communities in Appalachia or poor urban communities of people of color. We would make investments to create opportunities for individuals. The science exists. I think it is really breaking through the resistance that many of us have to it. And I think there was a report last week that came out, I think, from Citigroup that showed the cost, the trillions of dollars that racism is costing the US economy. There have been similar reports from the Kellogg Foundation and from Altarum Institute showing that having this degree of racial injustice and not capitalizing on the human potential of such large segments of our population is costing the US economy money. It's in our national best interest to do it, to make those investments. But we have to have a different frame of mind and a different, to buy into the benefits we would receive, we all would receive, and the fact that we have good evidence of solutions that would work.
Thank you.
All right, we have some questions coming in. So the first one is, Dr. Williams, would you be willing to speak a little bit more about the intersection of gender? So for example, how women fit into what you've presented.
I'm not sure I fully understand the question, but I think of populations of color, both men and women are disadvantaged. So whatever we do needs to include both men and women. So it's not about one group, it's about all. So I'm not sure if there was something else the question was trying to get at, but yes, we do need to include males and females, everyone.
All right, so the next question is in regards to COVID and how it impacts underserved communities. Given the economic impact on communities and frontline workers and low-paying jobs, where does this go now?
It's a challenge. I think there was a study there was a special program today at the Harvard T.H. School of Public Health that released a survey that was released by NPR, the Robert Wood Johnson Foundation, and the Harvard T.H. School of Public Health that focused on the economic cost of these of COVID on communities of color. And it was based on a national survey and finding that very high levels of Latinos and African Americans are reporting severe financial difficulties as a result of COVID. And it makes perfect sense. I showed you before COVID came, the populations of color were already disadvantaged in income, already disadvantaged in not having wealth. And then COVID-19, we are talking about these elevated deaths. We are talking about the loss of life of breadwinners in the community, of people who brought financial help to homes. And now, in addition to illness, you no longer have that source of income. We're talking about essential workers who did not have the option of staying home from work, because if you stayed home from work, you don't get paid. If you don't get paid, how do you pay your rent? How do you feed your family? So the economic impact of COVID-19 is enormous on communities of color, and Congress has acted and has provided some support, needs to direct more support to communities of color to help those communities survive. These essential workers are playing an essential role in our economy, and we need to keep them afloat and save them from a potential epidemic of homelessness and huge food insecurity if we don't act to help those very vulnerable populations.
Thank you. Our next question is, how might we better bridge the empathy gap that divides us by group, specifically the tremendous empathy of some, for example, white evangelical Christians who support repressive politicians, seemingly without empathy for other disadvantaged populations, such as racial groups?
I literally think that is $1 million question. I wish I knew what the answer was. There are challenges that we have in building empathy. There are some promising initiatives that there are ways in which we can learn to tell the story of the disadvantaged populations in a way that emotionally connects with individuals, and so they feel the pain and feel the suffering, and it generates empathy. But I think we don't really, we are still limited. Our knowledge right now is still limited in how best we can build the empathy gap. I think we do need to work with communication specialists, and some research in psychology finds that you can take the same story, and just by changing a few adjectives and just slight wording changes, it can be more successful in bridging the empathy gap. So I do think it's an important area that we need to identify how we can better tell the story of the plight of disadvantaged populations in ways that people connect emotionally with those stories and feel this is unacceptable in our country and we can do better and we need to do something about it. We see outbursts of empathy sometimes in the United States when there is a disaster occurs, thousands of miles away around the world, and people are using their cell phones to text money to help. So I think we are a compassionate people, but we have to first connect with the story, and we need to find how we can best do that in optimal ways.
Thank you. Our next question is, can you talk about the intersection between capitalism and the return on investment of these interventions? Do you believe that there is evidence that suggests that these racial problems actually sustain our economy?
No, the evidence is quite clear. Both the socioeconomic gaps in health and the racial ethnic gaps in health are costly to the economy. One analysis by Tom Leviste and Daryl Gaskin from Johns Hopkins showed that the racial gaps in health cost the economy $315 billion a year. So it's costly. And the biggest cost is not the additional healthcare costs. The biggest costs are the lost productivity costs. If you have people getting ill at very young ages or being disabled at very young ages because of the earlier onset of disease, you are reducing the economic productivity of the nation. You are hurting America's global competitiveness. So it's actually in all of our best interests that we eliminate these inequities. Let me give you a concrete example. Come with me to 2060. In 2060, the majority of people on Social Security will be white. In 2060, for every person receiving Social Security benefits, only 2 American workers will be paying into the system. One of those 2 will be Black or Latino. They are in elementary school today or in kindergarten today. So if we want a viable Social Security system for all of us in the future, everything we can do now to ensure that those children of color have the opportunities to become the best that they can be, to become productive by giving them high quality educational opportunities and access to good employment opportunities. That's what we need them to be doing back in 2060 so they can pay into the Social Security system so that the system would be viable for all of us. It is in our best collective interest.
Thank you. Our next question is in regards to COVID and remote learning. So have you done anything to look at the effect that remote learning will have on education by socioeconomic background?
I have not personally done anything on that myself. I do think that there are reports. It showed up even in the survey I mentioned that was recently released by NPR. That showed that for Black and Latino families, they were more likely to report not having access to broadband, not having reliable internet to educate their children. So there's reason to believe that some of the challenges, I think some of the challenges for rural populations also will be serious. That COVID-19 and having to work do teaching from home without the resources to facilitate it could be a major challenge for many American families.
Thank you. Another question, how can we best educate those who deny that social and racial inequities exist? As polarized as citizens as we are in this country, especially with those who are seemingly unwillingly to listen. So just to summarize,
yes.
I guess, yes, how can we best educate people who would deny that these social or racial inequities exist?
I do think we are in a terribly polarized country at this moment. If you wanted evidence, the debate last night illustrated how polarized we are. Our political leadership is polarized. And I do think as a nation, I think the academic sector, the philanthropic sector, we need to come together and find ways of how do we develop some credible voices that all Americans could listen to and can trust, and how do we develop trusted information that everyone would agree to. There is so much misinformation today, and people are so selecting only those facts that they like, and categorizing others as alternative facts. That is a problem for our democracy long term, and I do think we need to find ways to come up, at least we can agree on what the facts are, even if we see different pathways to solutions. We should be able to agree on what the facts are. And I do agree it's a challenge, and it's one that we need to come together as a nation and put our heads together to solve.
Thank you. Our next question, I'll just read this. It says, I would be interested in Dr. Williams' perspective on universal basic income and whether that combined with a slew of additional support and intentional institutional change regarding health, early intervention, et cetera, could be useful in uplifting underserved communities.
There are multiple pathways to get into where we need to go in terms of building these communities of opportunity. A universal basic income is certainly one option that could be done. I don't think it's necessarily the only option, but it's certainly one that has promise. I think we should try. I mean, American innovation, American ingenuity, we should try. Different states, different cities can try a range of strategies, and let's assess them and assess their impact. But it's a shame that in a country as wealthy as ours, we tolerate the high levels of poverty that exist in this country. And we have witnessed in recent years of truly the rich getting richer and the poor get in prison has been the reality in our country. And we can do better with more equitable access to the resources and opportunities of American society. So there are lots of strategies that we can pursue to get there. And I don't think it's only one, but the ones suggested are certainly possibilities.
Thank you. Our next question is, have you been invited to present these findings and recommendations to high-level state and/or federal policymakers? And if so, what sort of reception have you had?
I certainly, certainly there is interest in some quarters for information like this. I did have a presentation maybe several weeks ago with the Democratic Senate staff about thinking about COVID-19 and the challenges we made. They found it very helpful and useful. I think I am certainly not the only. There are many other academics out there who are proposing innovative solutions to the challenges we face. So I think one of our challenges really is that we are very rigidly politically polarized, one, and two, this problem, the empathy gap. We don't see it as in our best interest. We don't see that it's about all of us, and that when one segment of America is hurt, all of America is hurt and is disadvantaged, and we need to have that larger vision of a commitment to doing well for all of us.
Thank you. I have another policy-related question. So what do you see as some of the most pressing policy issues and efforts that can be promoted to improve racial equity?
We need to start early in childhood. That the evidence is quite clear. I served on the Robert Wood Johnson Foundation had established a bipartisan commission entitled the Commission to Build a Healthier America, and we had representation from both the sides, both political parties and a broad range of sectors of the economy. And one of our strongest recommendations was to invest in early childhood development. One of the benefits of investing early in childhood is that those children have the rest of their lives to benefit from the advantages they would get in terms of, as I showed in the example of the Abecedarian project, you have better health, you have better academic performance, you have better vocational skills, you have higher income. The Perry Preschool Study as an example of one study that shows an early childhood program in Michigan. For every $1 invested, there's a $17 return to society because of all of the ripple benefits linked to that. So that would be one place to start. And the second place is to improve access to employment opportunities for parents of children. We can improve the lives of children by improving the lives of their parents. There's a lot that can be done, but we have to begin, and we need to make a commitment to do better and to begin somewhere.
Thank you. Our next question is the medical legal partnership that you mentioned exclusive to BMC, and what would it take to expand that program?
Great question. The medical legal partnership was born at the Boston Medical Center, but it's in more than 200 hospitals across the United States. It's such a big movement that the medical legal partnership has an annual conference where hundreds of people gather to share ideas and successes of the medical legal partnership. So no, it started in the pediatrics department of the Boston Medical Center, but it's in hundreds of hospitals across the country. And there are other similar programs. Rebecca Oni had developed a program somewhat like that, using college volunteers to staff the admissions desk and would screen patients for the problems that they face. And then it would be the job of these student volunteers to link that client with a resource that existed in the community. So there are multiple options. There's a recent report from the National Academy of Sciences on meeting the social needs of parents, of patients, that shows the ways in which it can be done. So there are truly lots of opportunities of what we can do. And we can even go back to Jack Geiger and the first community health center that he started here in Boston and then opened one in Mississippi. And one of the things that he did in Mississippi was the doctors at that community health center could write prescriptions for groceries that could be filled, paid for by the pharmacy, but filled at the local supermarket. So I think there are lots of ideas, and there's a history of being creative in the healthcare space and finding ways to meet the needs of patients.
Great. Our next question is, do you think that setting up community-based healthcare facilities using combined public-private funding could help improve healthcare access for people of color and lower income backgrounds?
Certainly. I think community health centers have been very successful. They are a safety net in many communities. We need to ensure that they remain well funded. We have to be concerned about the impact of COVID-19, and many persons who, populations of color have been hard hit. Many persons who haven't died have been left with residual illnesses, respiratory, cardiovascular illnesses as a result of having COVID-19, and now they have pre-existing conditions, and we really need to pay attention right now to what we do in ensuring access to care, and community health centers are certainly one option to doing that. I'll give an example of a program I visited in San Bernardino, California. Loma Linda Medical Center is an academic health center 2 miles from San Bernardino, which is a very poor city in the United States. And they had a federally qualified health center, and they rebuilt that center and made the top floor of that building what they call a gateway college. In the San Bernardino school system, less than 20% of all students who complete high school go on to any higher education. And so there are huge challenges of low income and unemployment. And this Gateway College, built as part of this academic center's outreach to the community, using some of its community benefit dollars, is providing access to entry-level jobs within the healthcare system, like as community health workers and other medical assistants. And I met with some of those young people who were in that program, and they had just been inspired by the experience, that some were thinking of going on to careers in medicine and nursing and so on. It shows that if we can only create opportunity, that's what our communities need. Create opportunity for them so that they can see themselves and we can expand their vision of what they can be done. what they can do. And that would make a big difference. So there's a lot of opportunities that we can do by working with our schools and with our communities to expand opportunities for young people.
Pardon the interruption. I'm cognizant of the time. I wonder if we have time for one more question.
Mm-hmm. Yeah. So our last question here, I think this is probably a good one to end on to sort of tie everything together. So this attendee asks, I struggle with the emphasis and reality that these issues are both systemic, as you addressed in your lecture, and there's also the empathy gap, which seems to be about individual perceptions and manifestations of racism. How do we bridge between those two, the individual and the structural and institutional?
It's a great question. They definitely are connected. I mean, the structural inequities exist because many of them are imperceptible to us. We don't see them. They are built into policies and procedures. And that's why many are talking about the fact that we need not just a cultural competence, but we need structural competence, because many of our biases and implicit biases and unrecognized racism has been built into the normal operations of our institutions. And we need to understand that and dismantle those structural dimensions. At the same time, you're right. We need to have political will, and we need people will act and will be mobilized to say this is unacceptable in our country. When they feel that it's outrageous, when they feel that this is unacceptable, when they feel the pain and the suffering of those who are disadvantaged. So the two things work together. The structural policies are in place. We need to identify, understand them, and we need to find ways to build the political movement, build the political capital, build the political will that we need to address them. And part of that, it begins with feeling the pain and the suffering of others. So the empathy gap is a piece of it, but it's not just at the individual level. It has repercussions for us as a society and how we think and what our larger culture views issues and the challenges of populations. Again, let me thank you all for your great questions and for your time and attention this evening.
And again, thank you, Dr. Williams. And I'm once again, as the many years have shown of working with you, listening to you, learning from you, I find myself thankful, deeply in awe of your knowledge, of your ability to explain extremely complex problems in a way that it touches our heart and it motivates us. I want to thank you again, and thank you, all of you who will join us this evening. Today's Hubie Jones Lecture Series serves as the inaugural presentation for our Center's Health Equity Speaker Series. Please visit our website, ciswh.org. It's better when you see it written than when you hear it pronounced by me. So you go to the right site so you don't end up somewhere else. Please go to our site for updates on our work and future events. Again, thank you very much, Dr. Williams, and have a good evening, everyone. Thank you.